What's up, beautiful people? Another day, another study. The relationship between inflammatory markers and cancer is complicated and requires nuance. There are studies using things like HSCRP, which is probably the most well-known inflammatory marker as far as number of clinical studies. Studies do show an association with cancer. However, Mendelian randomization studies, which are an attempt at observational studies to show causation, do not. And I think that's probably because genetically elevated CRP is different from conditions that cause CRP to be elevated, and that genetically elevated CRP may not have all the same downstream effects. It also could be some reverse causation that people who have cancer have higher inflammatory markers, and that's why we see the association. But I think there is a difference between genetically determined or genetically associated CRP elevations and actual conditions that elevate CRP. CRP binds to pathogens and damaged tissue. It activates the early complement system. It promotes other functions, can affect nitric oxide signaling, and activates immune cells in the presence of IgG. So some of those functions need there to be damaged tissue or infections or other things that happen for it to work, which is why we may not see an association in those genetic studies. But anyway, we know that certain elevated inflammatory markers are associated with an increased risk of cancer diagnosis and cancer deaths. This is an increasing area of study, and that's the overlap between immune-mediated inflammatory diseases, IMID, previously also called autoimmune disorders, and cancer risk. This retrospective cohort study examined the risk of first cancer occurrence in individuals who have IMID. So at baseline, those with IMID have higher rates of comorbidities, including hypertension, cardiovascular disease, and diabetes. This is something we often see when we take care of these patients, is the other comorbid conditions. During the 5-year follow-up period, patients with IMID were 32% more likely to be diagnosed with cancer. The risk was highest in the first year of diagnosis, 83%, and then declined to the 5th year, 20%. So that's interesting that the risk is higher in the first year. This may be for numerous different reasons, but it's possible that in that first year before treatment, inflammatory markers are the highest, disease activity is the highest, and that confers a larger risk of cancer as opposed to 5 years down the line when that person is more than likely being treated and that condition is being monitored. Now, there are significant limitations. This was a retrospective study based on ICD-9 codes. The patient group was patients that were discharged from the hospital. So that's a different patient population than those who may not go to the hospital. There's a lack of information on important confounders such as smoking, alcohol, socioeconomic status, and there's lack of information on treatments. So whether they got biologicals, steroids, or other type of treatments, and there's no information on disease activity. But overall, myself and other practitioners I know are really paying attention when someone's diagnosed with these things, making sure that they're getting appropriate cancer screening and treating the other comorbidities that we see along the way. So I look at this study as informing or helping to inform what we do with these patients and knowing that their risk is there in some studies. And so the best thing we can do for this now is making sure that people get screened appropriately.